Hi, I'm Whitney Espick, the CEO of the MIT Alumni Association, and I hope you enjoy this digital production created for alumni and friends like you.
Welcome to our inaugural program of a webinar series featuring experts from across the globe. My name is Rudayna Abdo with the MIT Arab Alumni Association, which is an organization that was established to connect MIT with the Arab world and to create a space for alumni to collaborate. Today, we're joined by three esteemed physicians who are going to give us their perspective on the COVID-19 and this impact on their daily practice. This will be a no participation, a no voice participation webinar, but we ask for your, please provide your questions in the Q&A tab at the bottom of your screen. You can enter your questions. We will have each speaker speak for about 10 minutes, followed by a short Q&A. It is my great pleasure to introduce our three speakers. From Maryland, we've got Dr. Laura Fayyad, an MIT alumna herself, Professor of Radiology, Orthopedic Surgery and Oncology, and the Chief of Musculoskeletal Imaging at the Russell Morgan Department of Radiology and Radiological Science at Johns Hopkins. Dr. Fayyad is the lead radiologist at the Musculoskeletal Tumor Imaging Center of Excellence. And in California, Dr. Lama Rimawi, also an MIT alumna, who founded the Care Pediatrics in Wellesley, Massachusetts, and now has a private pediatric practice in Palo Alto, California. Dr. Rimawi has lectured at Stanford Medical School for the past 5 years, focusing on early infant development, and is the co-founder of Tastery, a children's food-focused startup. And over in the United Arab Emirates, Dr. Martine McManus is Head Group of Pathology and Laboratory Services for VPS Healthcare, a multinational healthcare group based in Abu Dhabi. Dr. McManus has clinical and administrative responsibility for 27 hospitals across India, Oman, Bahrain, and the United Arab Emirates. Dr. Fayyad, you are working at the institution that puts out the COVID-19 data that we all consult every day. Can you please shed some light on what's happening at the institution and what the impacts are on your radiological practice? The floor is yours.
Thank you, Rudayna, and hello to everyone from Baltimore. It's really a pleasure to be with you here today. So Rudayna asked me to share my perspective with you as a radiologist who is not so much on the front lines every day, although I'll tell you that I'm married to a pediatric surgeon who is on the front lines on a daily basis. And so I can share with you what we've learned in our line of work. So as she said, by way of background, first, I work at Johns Hopkins, and Hopkins has been in the news a lot because it's one of the institutions that's leading the effort to fight coronavirus around the world. And as she mentioned, we put out the map that tracks coronaviruses globally every day. So Hopkins is a tertiary care facility, which means that we have some of the sickest patients in the state with very complex problems. And for COVID-19, what this means is you can be treated perfectly well in your community hospital, of course, but when the hospital system gets overwhelmed, some of those patients may transfer to Hopkins. And also, if the disease progresses to be very severe, some patients may transfer to undergo some more extreme measures, such as, for example, if somebody needs to be transferred for procedures such as ECMO, which is essentially a heart-lung bypass procedure. So we deal with some very complex problems. At the same time, we serve our immediate community, which is inner city Baltimore. And this is, generally speaking, an underprivileged, under-resourced community that may not have access to all the protective equipment or perhaps communication to understand why we need to do social distancing, or maybe they can't do social distancing because of their living arrangements. So with the hospital taking care of the community, the state, the neighboring regions, and then being on the forefront nationally and internationally with this crisis, you can imagine that our hospital system could become overwhelmed without adequate preparation. So fortunately for us, we are located in Maryland, where we have a very smart governor who's shut down the state very early in the game here. And because of it, I think we've been able to flatten our curve in the hospital and in the state. So we do have a steady stream of patients with coronavirus in the hospital, but we are well prepared and not overwhelmed at this point. And I should mention that most of the patients are adult rather than children. So there are obviously a lot of things we're doing differently with our practice now with coronavirus, but I'll just describe some of the measures we've taken. So one thing is that we've put a halt to all the elective procedures and surgeries at our institution, which means that everyone that can stay out of the hospital will stay out of the hospital and not be exposed. This also means that if you're a patient with chronic back pain or knee pain who is otherwise going to receive, undergo spine surgery or knee surgery, then you're going to have to wait at home and be on pain medication a little bit longer until the time is right for surgery. This move to stop elective procedures helps us to free up floor beds and ICU beds, of course, for all the COVID-19 surges that may occur. The other thing is, and you'll hear, I think, from Lama about telemedicine practices and so on. The other thing you've heard about in the news a lot is nursing homes and prisons. These are very crowded facilities where we've seen a lot of COVID-19 outbreaks. And what we've done in our hospital systems is send specialists out to these facilities to help with the care on site rather than bringing everyone into the hospital. And that has also helped with containment of COVID-19. Okay, so I'm a radiologist, and so where does radiology fit in with all this? You probably know there's diagnostic radiology and interventional radiology. I'm a musculoskeletal radiologist, which means I do some intervention and some diagnostic imaging. So our interventional radiologists are actually very busy in the hospital these days because they can be found at the bedside putting in central lines, various drains and catheters and tubes in these patients to help with their care. The other thing that interventionalists do, they do more specialized procedures such as biopsies. And as I said before, elective cases are not done, but anything urgent or emergent is still performed. So this would be a patient who, let's say, has suspected cancer or infection. We would go ahead and proceed with a biopsy so that the care would continue. The other part of my job is diagnostic radiology, which means I interpret images. And we have kept all our outpatient imaging centers open because, as I said, similar to what we were talking about with the biopsies, there are patients who have cancer, infection, who fall off a bike, who get into car accidents, whatever it is, that need imaging and care. And so these outpatient imaging centers continue to provide that care. The other thing is there are COVID-19 patients who are not hospitalized, who are sitting at home that may deteriorate, their condition changes in some way, and maybe they don't need to be hospitalized, but their doctor wants them to be imaged to see what's going on. And so the outpatient facilities are there for those patients as well. So here are some things that we've seen with the outpatient imaging is that patients who are coming in for reasons other than COVID-19, such as, for example, let's say a patient who has colorectal cancer who's being imaged for suspected metastatic disease, we have found in some of these patients that there is COVID-19 in their lungs, although they exhibit no symptoms, outward symptoms of COVID-19. So these are asymptomatic from the COVID-19 standpoint. So this should probably not be a big surprise to anyone because we know that some of us are walking around with COVID-19 and don't know it, or we have had it in the past and we don't know, we didn't know. And there have been a couple of studies very recently in New York City, in Boston, and Los Angeles, 3 cities that have sampled random parts of the population and shown that somewhere between 3% and 21% of people who have no symptoms at all are walking around have COVID-19. So it's not a big surprise that we do see this in our outpatient imaging facilities when it's unsuspected. So the other thing I want to discuss is how do we use imaging in COVID-19? So we do not use imaging to make the diagnosis of coronavirus because this is done with the nasal swab. However, we do use imaging to look for conditions that are superimposed on COVID-19 that can be treated, so treatable conditions. So most commonly we use chest X-ray or chest CT in our institution, and the most common superimposed condition is something like bacterial pneumonia, which can be treated with antibiotics. We also see pulmonary embolisms, which are clots in the lungs in these patients, and of course there's treatment for that. So that's the reason to image these patients. Now, coronavirus affects the lungs in a very predictable pattern, and so there was some thought out in Asia that maybe we could be using chest CTs to screen patients for COVID-19 rather than the nasal swab, but we don't do that, and that's not widely advocated because it is an expensive resource and there is some radiation associated with it, and most likely it's not that specific. Just so happens at this time that the features associated with the COVID-19, the lung abnormalities that we see appear to be pretty specific and characteristic to the disease, but that's probably because the pretest probability of having this disease right now is pretty high. But as we move into the fall and the winter next year with other viruses coming into play and the flu and so on, it's likely that the lung abnormalities that we see by chest CT are probably not that specific for the disease. The other reason that we do not want to image everyone with COVID-19 is that we are thoughtful about the way we expose our healthcare workers, and taking chest X-rays, doing, or as advocated in Europe, doing ultrasound on the lungs, or chest CTs requires healthcare workers. And as these healthcare workers become exposed, they get sick and they have to be replaced with other healthcare workers. And of course, we know that healthcare workers are a limited resource. So I think I'm coming to a close with my presentation here. In my parting thoughts, I just hope that I've conveyed to you that in our situation, we are under control, our hospital system with this virus. And it's important that everyone understands that whether you have COVID-19 or other conditions that need to be treated, you can come into the hospital to get treated, because one of the fears right now is that people are staying home and missing the opportunity for treatment of their heart attack or impending stroke rather than coming in because they're afraid to come to the hospital. But things are under control as far as, in our system anyway, and we do want to encourage that. We do not know why it is, but we are seeing fewer heart attacks in our system than we would expect, for example. So with that, I hope that everyone stays healthy, and I'm happy to take your questions at this time. Thank you.
Thank you very much, Dr. Fayyad. We have a couple of questions here, which I see if you can address, please. Are you able to address the false negative rate of the swab test? Can you?
Okay, so it's not really my field exactly because I'm really an imager, but maybe some of the other panelists can address that a little bit better. I think that's still an evolving issue with the false negative rate, and I can't really, as I said, it's not. I think some of the other panelists could probably answer that a little bit better. But if you have any questions about imaging, certainly let me know.
Yeah. On the imaging side. Well, there's another question, and again, it may be deferred. We've seen a large number of COVID patients, but expert estimates around mortality rates vary tremendously. Why is that? And what do you think can be done to handle it better and to equalize some of the?
Okay. All right, so the answer to that is that there are a lot of unknowns about the asymptomatic population. So even as I was saying with this sampling that they did recently in New York and so on, that somewhere between 3 and 21% of people are asymptomatic and spreading disease. Well, there are other estimates that maybe 50% or 85% are asymptomatic. So in that number, it's not really clear. Some people are including mild conditions and asymptomatic. And when you say mild, it means you're actually holed up in your basement with high fevers and cough and very, very sick for 2 weeks, but not actually hospitalized. So the death rate, because we don't know the asymptomatic rate so much, we don't know how many people are actually affected. The death rate is unclear. We don't really know what our denominator is right now. So the way we would, learn that, obviously, is to test everyone, figure out, who has it, who doesn't, and how does each person do with it. And then you'll know the death rate. So obviously we're limited with resources right now, with testing, but that's really what you need to go back to a normal life and also understand this disease better.
How much did your non-emergency imaging volume drop? And what's your thought on recovery of normal imaging and the backlog of missed procedures?
Yes. So I would say ours dropped somewhere between 50 and 75% at least. As I said, we're still treating everyone that has to be treated, like cancer patients are coming in, infection cases, injury, and so on. How would we come back? So we're in the process of developing plans to bring all that back. And some of the things we're doing are to speed up our protocol so that when we start back live and we have to see a large volume of patients, we're going to try to image faster and still get the same amount of information. And then we need to find processes in the waiting rooms, for example, to keep 6 feet apart, and methods of cleaning the rooms in between patients that's speedy enough to keep the throughput. So we're in the process of trying to sort out how and when we'll start back up, but it will require some social distancing. We do plan to test some of the people that come in. So right now, for example, all biopsy patients are tested for COVID-19 before they come to the hospital and are treated, so that we have an idea. So we may, if we have enough tests, be able to do that for everyone that comes in and alleviate some of the burden of what's required with a COVID-19 patient. So,
okay. Well, there are a lot of other questions, but in the interest of time, thank you very much, Dr. Fayyad. That was extremely insightful. And we're going to move over to California to Dr. Lama Rimawi. Dr. Rimawi, you operate in a high contact environment with children. Can you please tell us how your practice is changing now in light of lockdowns and social distancing and the state of the practice? Over to you.
Absolutely. Thank you so much, Rudayna, for organizing this incredible event. So I'm a pediatrician, as Rudayna mentioned, in Palo Alto, California, and we have had several changes that have affected our practice. I wanted to talk about 3 things specifically. One of them is the clinical practice. Another one is the telehealth aspect of medicine now. And the final one is children and families and how this affects them. In terms of the clinical practice, as Dr. Fayyad mentioned, one of the things that has had to change is our infectious control protocols had to really be quickly transformed to accommodate the fact that we might be seeing COVID-19 patients, especially in the pediatric population where a lot of kids are asymptomatic actually. So there was a mad scramble. We had to find enough masks and gowns, gloves, sanitizer, cleaning fluids, and just like the hospitals did, but we're much smaller. And we had to implement changes that would allow no contact between families. And as you can imagine, a pediatric waiting room can be quite busy. And so we ended up deciding that one patient could come with just one provider. Oftentimes families would come with multiple providers and siblings, both toddlers and older brothers and older sisters and so on. And so we have reduced that to just 2 people. We stopped using our waiting room actually, and because we need to see healthy babies, newborns that have just been born, they need to be weighed and checked, and the younger children still need their vaccinations to stay immune to all the other illnesses that they could be exposed to. We've decided that we generally will see sick patients. If we have to see them live, we will see them in their cars. So that's been quite a transformation. So despite all these changes, one of our key staff members actually very early on at the beginning of March acquired something that appeared to be COVID-19. She developed a cough and shortness of breath, and it lasted for weeks on end. At that time, our county was not allowing testing. So, well, rather they had very strict criteria for testing, not that they weren't allowing it, and she didn't fit the criteria. So we don't actually know if she really had it, but she was sick for a very long time. And unfortunately, one of the negative effects that happened was that she developed a severe anxiety around being in a medical office. So, and I'll touch upon that a little bit later when we talk about the effect on children and families. But yes, our clinical practice has changed quite a bit. And one of the big changes, of course, is telehealth visits. And telehealth has been actually a savior for us because we are able to see children without increasing their chances of acquiring coronavirus, without increasing the chances of their families acquiring it, and so on. So it's opened up an incredible world. And one of the aspects is, you know, historically, adoption of telehealth has been limited by physicians as well as families. People want to see their doctor face to face and vice versa. And that's completely transformed. So we're able to see the patients now are able to see their doctors without going the distance. If they live far away, it's much easier to see people. You can schedule specialty visits and without having to leave your room, which is, you know, great in some ways. And it also allows us as primary care providers to actually sit in on conversations that in the past would have been difficult. If there was a complicated patient that was being discharged, for example, we can sit in on the conversations between the specialists just by dialing in. You know, historically, we'd have to leave our office and slot in time, go to the hospital, come back, and so on. It was really difficult to do. So there's a lot of opportunity there. The disadvantage, however, is that kids often can't tell us what's wrong with them. And so we as pediatricians do really comprehensive evaluations when children come in, and that is something that is really limited with telehealth. Often kids won't sit longer for a minute or two, especially the younger ones, because it's super boring to look at a screen with a boring doctor on it. And so we get really just a moment to check and see what's going on with the patient. I don't have a stethoscope. I can't check their heart and lungs. I can't check their bellies, their ears, their throats. So it is limiting in a lot of ways. And in fact, we have a colleague who fortuitously, the patient had to come in for vaccines, and she discovered a rare form of cancer in her belly that would not have been picked up for some time if the patient had not come into the office. So I think telehealth has an incredible, it's an incredible opportunity and has an incredible future in medicine, but I feel there's a long way to go in terms of the physical exam aspect. And for all you techie people out there, if you can come up with some incredible way to use the devices we already have to actually just increase their functionality so we can do those things, check those hearts and lungs and so on, it would be just such a huge thing for medicine. So the last thing that I wanted to just touch upon is the effect on children and families. And I think all of us have seen how difficult it has been. Children specifically have had a really hard time because they're used to moving around a lot, and the shelter-in-place orders and lockdowns have been very tough. The school closures, especially, they're used to spending a lot of time with their friends. So that has been a huge change, but also it's been a little bit terrifying for them. You know, most kids understand that they probably won't get super sick. Some do, you know, it's a very small percentage, but most kids do fine, but they're worried that they might give a fatal disease to their family. That's a super scary thought if you think about it. And the other thing is that they also worry that a family member might die. So it's been difficult, and I'm sure everyone has dealt with this in some ways. Kids tend to thrive in a really structured environment. And this pandemic has basically thrown that out the window. We've basically put them into chaos and said, we don't know how long this chaos is going to last. So super stressful, and parents are stressed out because they're working at home and trying to manage kids and work at the same time, which is really difficult. So it's, for the kids, it's the worst possible time to have a meltdown or regress in their behavior, but that's exactly what they do when they're stressed out. And so parents being stressed out, on top of that, you can only imagine how bad things can get. So we had reports from Wuhan actually of increased reports of domestic abuse. It actually tripled in one county in Hubei province during the course of the lockdown. And we unfortunately expect that that's what's going to happen. We saw that in Hurricane Katrina, that we had an increased rate of domestic abuse just because it's so stressful, economic uncertainty, and everyone's stressed out. So it's something that we need to watch out for. And one of the things that we've been thinking a lot about is what are the short-term and long-term mental health aspects for the children. Toxic stress, we know, can be really detrimental to children, not just in the short term. And generally, I think probably across the world, but certainly in the US, the amount of mental health resources available to children is very limited, even more limited than it is for adults. And so, they're actually, that's something that we're on the watch for. And there are a lot of resources coming out right now that can really help. Actually, there are some books that have been designed specifically to help kids cope and understand that they're not alone, that a lot of kids are feeling this way, and what kind of things they can do to help. And there are resources for parents to sort of let off steam or just talk to someone if they need to. But really the key for the kids is to have the parents make sure that they calm down as much as they can and de-stress if they can, and then try to address the issues with the kids, maintain a sense of safety and security for the children, and maintain as much structure as possible. Minimize exposure to all the scary stories out there, because that tends to amplify their worries. And so I think that there's a lot that we can do at home, but yes, we need to keep our eyes and ears open for what's coming next. And I think I'll stop right there because I probably went over time. And if there are any questions, I'm happy to answer them.
Super, thank you very much, Dr. Rimawi. Actually, I'm going to start with a question related to a conversation I was having with Dr. Fayyad just the other day, and she was mentioning how there's a higher occurrence of children having accidents and coming to hospital because they're out of school and getting to more accidents. Are you seeing that in your practice as well, and how is it handled?
So actually what's interesting is that we've had reports of a 20% increase in ingestion of cleaning fluids and disinfectants. And that was before our esteemed leader recommended it. So yes, there has been an increase, and it's a scary increase in the spectrum of things because everybody's situation has changed. People are trying to be really diligent about cleaning, for example, not thinking that, oh no, my toddler is going to go drink the fluid. So yes, I can totally, I haven't seen an increase in injuries in my own practice, but I can totally imagine that would be the case, absolutely, because the environment has changed and people are distracted. Parents who are working, when you're trying to do a call, just like I am right now, thankfully the kids are in school right now, but if they weren't, it's difficult to watch them, right? It's difficult to kind of do those things simultaneously. And plus the kids are stressed out again, so they might act out more. They might not listen as well in terms of not doing those things that are a little bit dangerous. So it's a difficult situation.
Thank you. I'll probably take two more questions. There's one question from asking, can you share any information on colleagues dealing with this problem in other countries? How is global collaboration? It's hard to get news from other parts of the world. So is there any cross-country collaboration going on in practice?
So I expect that in the tertiary care setting, there probably is a lot of cross-country collaboration. In terms of the primary care setting, I actually haven't seen that. There are a lot of message boards and chat rooms for primary care doctors to chat with each other across the country. I haven't really seen much of people from other countries contributing to those chat rooms. Perhaps they're available, but I'm not aware of it.
Okay. And then one final question is, somebody posed a question of hearing that in some metro areas, up to 1/3 of healthcare workers were not showing up to work, possibly out of fear of COVID-19 exposure, but certainly could be for many other reasons. This places added stress on the frontline healthcare workers who are getting into work. Have you experienced that in your practice as far as not having staff show up when needed?
Well, as I mentioned, one of my key staff people got sick very early on, and frankly, it was very difficult, and she developed an anxiety disorder around the illness, and so just coming to an office at all now has been difficult. We've had to find someone to replace her during this time period. And so I can imagine it's a scary situation, especially when you have someone elderly at your home and you know that you may expose them, or you yourself have health problems. I think that especially when there was limited access to PPE and masks and so on, I'm not surprised that some institutions had that. I would say that there are a whole host of providers that have gone out of their way to do what they can for people and at risk to their own lives. And certainly we've seen, I think in New York, they were reporting about 10% of the people who were getting sick were healthcare providers. And so that's a big percentage of people compared to the number of providers that are out there.
And is there a fear that there will be a shortage of healthcare workers in general and globally, actually, within your practice, pediatrician, pediatrics? Is there a fear that healthcare workers are going to become?
So there is a fear that there's going to be, so as the healthcare systems get stressed and providers get sick, you're going to find a further decrease in the ability of the health system to help patients. And as Dr. Fayyad mentioned, that's our big fear, because if this health system can't take those ICU patients, the patients that could have potentially been treated on ventilators are not going to survive because they simply don't have a ventilator. And yes, you can have 1 million ICUs, but if you don't have 1 million doctors to staff the ICUs, then it doesn't matter how many ICUs you have, right? And so anytime a healthcare provider gets knocked out, you actually are diminishing the ability to care for patients. In terms of pediatrics, again, a lot of our patients are asymptomatic, which puts the providers at risk, but not the patient at risk, right? And so, but the good news in that aspect is it probably affects healthcare a little bit less, because you're not going to see that inflow of really sick patients. But you will see the drops in providers that are available, at least for a time period.
It's interesting you're related to a teaching hospital, Stanford. I wonder if we'll start seeing many more applicants to medical schools and a lot of uptick in the medical students entering.
Or a drop.
Drop. Okay, I was thinking the other way. We need more healthcare professionals.
Yeah. It happens.
True. Well, thank you very much, Dr. Rimawi. I really appreciated your insights. And now we're going to jump 11 hours later to nighttime to Dr. Martine McManus in Abu Dhabi. Dr. McManus, you oversee one of the largest COVID testing labs in the private sector in the UAE. Can you please tell us about the state of practice in Abu Dhabi and the Emirates? Over to you.
Thank you. Good evening, everyone from Abu Dhabi. And thank you, of course, Rudayna, for inviting me to participate in this panel. It is a very, very challenging time. I feel very fortunate, actually, to be practicing in the UAE, because the government here has been extremely proactive and well coordinated in helping educate the public and giving everyone access to testing. In this country, there are a little under 10 million people in the UAE, and last week we surpassed 1 million tests. The government has opened drive-through testing centers across the country, And then they've also given people access to testing. If you are pregnant, over 65, have any underlying medical condition, or have COVID symptoms, the test is free. If you don't fall into one of those categories, the test is 370 dirham, which is approximately $100. So what we've had now is this very, very, very big demand for testing, which has been great in that the population's being tested. It has, however, of course, created a real problem for the labs, because now we have this excessive demand and not necessarily the capacity to match this demand. So there are approximately 30 labs across the country that are performing PCR testing. Everyone's doing the nasal swabs. Everyone does PCR. No one in the UAE is using serological tests, antibody or antigen tests. Everyone is doing PCR. This is great in that it's the gold standard. However, PCR testing is very, it's manual, it's quite laborious, it takes time. And when you have this enormous demand for testing and a testing capacity that doesn't match it, what we're ending up seeing is patients waiting for days sometimes for their results. So that's been one challenge that the labs, of course, have had to face. I know this is not unique to the UAE, but it's not something that we're accustomed to. So it's something that's quite stressful, I think, on the labs. The other thing that's actually completely unique is there is a global shortage of testing reagents, kits, all of the things that are required to actually run the tests. This is something that's unprecedented in my practice time, is that you now, when you are running out of stocks, you usually would just go to your vendors, your distributors, and order, let's say, another 1,000 kits to run another 1,000 tests. That is not possible anymore. Now you call your vendors and actually there are no kits coming into the country. There are actually not that many different companies that build the PCR machines. So what you have is an enormous sort of frenzy of across the labs, across the world, to use the same analyzers, the same kits, and this has actually created a very significant global shortage. And that really impacts your ability to consistently test. And that has been something that we have actually suffered from quite a bit. The UAE is a very small country. Our fatality rate is very, very low. It's well under 1%. So in terms of global allocation, we're always going to be, we're never going to be a priority because our population is actually doing very well, relatively. And this has actually been a real challenge for the labs. You also have technologists coming to work and being exposed to the virus multiple times a day. And this is also something that's actually very challenging, not unique to the lab per se, but the idea that you come to work and you're actually afraid of contracting the disease that you're diagnosing. This is something, again, that we're not used to. And that's very difficult. Approximately half my staff is currently infected with COVID. That's never happened before. So you have staff reductions and of course, increased anxiety. Every time someone leaves the lab to go into quarantine, you have more work for those remaining and increased anxiety that they're actually going to also get it. So we're having to swab the entire staff almost every week now and really monitor where people go, how they travel home, do they ride the bus home? If they do, how many people are on the bus? When they go home, how many people do they live with? Are any of their roommates infected? All of these things these are never questions that you actually ever think about. But now you actually have to. there's a degree of vigilance required, and it's really unprecedented, really unprecedented. So you sort of get to know people on a different level. You become very, very well acquainted with their roommates and who they live with and whether their families in their home country are potentially infected. All of these things become very, very real on a daily basis. So this has really changed the way you approach your work. It changes the way you interact, and it gives you sort of a greater sense of responsibility, I think, not just for the samples you're getting, but for the population at large. There's a sense of community and a need for vigilance, which is not necessarily a bad thing. This may actually outlast this pandemic. I think it's kind of created a sense of community in a way that that's really, really unique, actually, and hopefully will be one positive consequence of this, that people will actually work together more. There'll be more of a pooling of resources, a little bit more of vigilance for one another. That's something I have seen here, and that I actually hope will outlast this pandemic.
Thank you very much. Having lived in Abu Dhabi myself for a number of years, and knowing that the demographics of the UAE is quite young, do you think that is a factor for the low rate of affection or the low mortality rate, the young population there?
Absolutely. Absolutely. We have such unique demographics here. 10 million population, 85% of that population are expatriates, almost entirely from Southern Asia, India, Pakistan, Bangladesh. That 85% are predominantly male. They are men. 72% of the overall population is male. Of that male population, 60% are between 25 and 50 years old. So you have such a large male young population that they are the ones that we're actually seeing in the hospital. They come in and they tend to, because they're here working, they tend not to have underlying medical conditions. So they are being hospitalized primarily to separate them from their roommates. They're not being hospitalized because they are sick per se. They're being hospitalized because they live in a group home with perhaps 6 other people. So they have to be separated from their roommates. And these are the people who are filling the hospitals. And they tend to do very, very well, actually. They're really quarantined to separate them. They are monitored. They still require 2 consecutive negative nasal swabs to be released, but that tends to take place in approximately 10 days. So most of our patients are young, they're male, they're not really, they don't have the kind of respiratory failure that you're seeing in a lot of the other countries. And they are being released within one week to maybe 10 days. So I think this is why the UAE's fatality rate is actually quite low.
We heard earlier about telemedicine and telehealth. Are there examples of telemedicine being used in the Arab world, such as medical practitioners being able to consult with specialists for complicated cases, to your knowledge?
Yes, telemedicine. We are trying as much as possible to keep patients out of the hospital. So now, maybe with the exception of the oncology department, any other patient that now wants to come to the hospital actually has to do a telemedicine appointment. And there's sort of a screening, a kind of a triaging that takes place first via telemedicine before patients come. I think the main exception being patients with that have chemotherapy needs or other chronic conditions that require regular appointments. But outside of that, every effort's being made to keep patients out of the hospital. Absolutely.
All right. And we'll just take one last question. Researchers at MIT and Harvard are piloting a project for testing COVID concentration in the sewage system of Cambridge. Are you aware of large-scale innovation testing pilots taking place in the Middle East, in the UAE, or around the world, sewage testing. This is something I had heard of in the Netherlands here as well, COVID being found in sewage.
I haven't. I know that there was the idea that you could actually detect the virus in fecal samples, but outside of that, and that I haven't actually seen done. But in sewage systems, no. That I haven't actually read about that yet. No.
Okay, so it'd be interesting if there are cross collaborations across different disciplines, the public works and the health professionals happening, and how that will transform medical practice across the board.
Yes.
Well, thank you very much, Dr. McManus. And we have come to the end of our program. And I want to once again thank Dr. Laura Fayyad in Maryland, Dr. Lama Rimawi in California, and Dr. Martine McManus in Abu Dhabi. It was really thought-provoking and very insightful session, and just left us teasing, wanting more. And for all of you, thank you very much for joining us for our first session. Keep an eye out for our next programs. Look out for our social media channels. This is the first of a series. And from all of us at the MIT Arab Alumni Association, thank you. Stay healthy and goodbye.
Thanks for joining us. And for more information on how to connect with the MIT Alumni Association, please visit our website.